Good day. Our case study is a case report on the middle cerebral artery aneurysm treated by rapid ventricular pacing. The anatomy. The middle cerebral artery is a terminal branch of internal carotid artery and is a part of anterior cerebral circulation. The MCA supplies many deep brain structure, the majority of the lateral surface of cerebral hemisphere and temporal pole of the brain. It travels from the base of the brain to the lateral sulcus before terminating on the lateral surface of the brain. The surgical classification divides the middle cerebral artery into 4 segments, which give rise to the total of 10 branches. The middle cerebral artery arises within the interpedicular fossa from the internal carotid artery from the lateral angle of the circle of Willis. It curses lateral between the frontal and temporal lobes, transversing the Slavian fissure. It then passes over the superior surface of the insula, where it bifurcates into the superior and inferior trunks. The trunks travels together to the Slavian fissure towards the lateral surface of the brain.
Concern, a 46-year-old man came to our hospital with intermittent right side headache for 5 years and left lower limb numbness for 3 months. The test and measurements is MRI or the magnetic resonance angiography uses a powerful magnetic field radio waves in a computer to evaluate blood vessels and help identify abnormalities. This exam does not use radiation and may require an injection of contrast material. The contrast material used in MRA is less likely to cause an allergic reaction than the contrast material used for computed tomography or the CT scan. RVP or the rapid ventricular pacing was used to reduce blood pressure during the MCA or the mid-cerebral artery aneurysm repair and to lower the risk of intracranial hemorrhage during the procedure.
For treatment management and outcome, the general anesthesia was performed by a team consisting of anesthesiologist and nurse with experience in cardiac intervention and surgery. The patient was given 1 mg midazolam, 0.5 gram fentanyl, 1.0 microgram per ml propofol target controlled infusion, and levetiracetam to induce anesthesia. The respiratory rate and cardiac function was closely monitored. Local anesthesia was performed by injecting 2% lidocaine around left radial artery. A French introducer sheath was placed in the radial artery to set up a line. On examination, the blood pressure was 106 per 56 mmHg. HR was 56 beats per minute and the oxygen saturation was 99%. A 6-FR catheter was put into the left axillary vein under ultrasound guidance to set up C-line. A 5-FR flow-directed pacing catheter was inserted into the right ventricle, and the probe was inserted around 45 cm and reached the right ventricular apex. Correct positioning of the pacing electrode was confirmed via continuous ECG monitoring under pacer stimulation with a low pacing threshold. External defibrillation pads were placed on the chest wall. The patient was put in supine position and his head was turned toward left side around 20 degrees. Cut skin and temporalis and exposed frontal lobe and temporal bone. And opened a window in this area, incised the dura, and started to dissect the aneurysm. When the aneurysm was fully exposed, the RVP was started to reduce BP. RVP was induced totally 4 times during the entire procedure. Twice was induced when isolating aneurysm and twice was started during clip placement. The first RVP lasted 120 seconds and maximum HR was 130 BPM. And lowest BP reached 58 by 38 mmHg. The second RV lasted 50 seconds and the maximum HR was 150 BPM. The lowest BP reached 39 by 21 mmHg. And the third RVP lasted 50 seconds and the maximum HR was 160 and the lowest BP reached 29 per 26 mmHg. Least 3 minutes gap before between each RVP episodes. Every time RVP was introduced, the HR reached the maximum HR in 5 seconds, and the average BP dropped to the lowest level after the BP increased gradually in 50 seconds, and eventually it reached to 58% to 80% of BP before RVP induction. RVP significantly reduced the tension of aneurysm when isolating the MCA-M1 fragment and decreased the risk of rupture. Once the aneurysm was fully exposed, we introduced another 2 episodes of RVP to clip the aneurysm. Intraoperatively, indocyanine green video angiography was used to verify aneurysm occlusion as well as parent vessel perfusion after each clip placement. The patient was in a very stable condition during the entire procedure. No vasoactive and anti-arrhythmia drugs were used, and no adjustment of doses of fentanyl and propofol as well. The MCA aneurysm was clipped successfully. The temporary pacing was removed after the surgery. The surgery lasted 6 hours and 40 minutes, and total RVP time was less than 5 minutes. The patient was transferred to a post-anesthesia care unit for observation around 2.5 hours after the patient woke up and Glasgow coma score were more than 6. The patient was transferred to ICU. CT scan confirmed no intracranial bleeding and there were no arterial blood gas changes during the after RVP. Compared with before RVP, the biomarkers of cardiac muscle damages including CKMB, troponin T, and ProBN were increased at 24 hours after surgery. 7 weeks after surgery, the patient was fully conscious and cooperative. Muscle tone of right side extremities were grade 5 and left side extremities were grade 4. CTA confirmed MCA aneurysm and the patient was discharged.